When I started doing ACL reconstructions, the outside-in technique was the preferred two-incision technique. That seemed to work well, and from what I knew of anatomy, it seemed to get the graft in the appropriate location. When the transtibial technique came out, I never got the feeling that I could put the tunnel where I wanted it. So the reason we have stayed with the outside-in, now flip cutter technique is it's easier. We're looking at the knee the way we're used to looking at it. We don't have to get in hyperflexion. We can get it in the normal position, unlike the transtibial and unlike the medial portal. We are not in the high degree of knee flexion with a drill that we have to worry about and a reamer that we have to worry about doing damage to the femoral condyle. So it's also visual, and if you are, especially in an academic situation, working with young residents, I think you can make them see everything perfectly aligned during the time that you're teaching and learning this technique. I think it's easier to learn. So the trick on finding the femoral tunnel is find that reference point. Find where the articular cartilage ends and the synovial reflection begins. And if one marks from there, straight distal in line with the femur. Now, it's distal, but with the knee flex 90 degrees, it's coming from deep in the field to close to the arthroscope. So if you find that combination of that's a starting point and this is a direction, you'll go straight through the middle of the ACL footprint. You see the footprint, and then you can easily put the graft, put the tunnel in the middle of the footprint. We took a series of cadavers and did transtibial drills, and then did the outside-in technique in comparison, and then stripped away all of the soft tissue and found out that the transtibial pin that you would use for making the tunnel did not even touch the ACL footprint. In other words, you're trying to put it in the correct position in a big footprint, but even the pin missed the center of the footprint. Now, once you put the reamer in there, of course, there was some overlap. But at the same time, the outside-in technique was able to put us very close to the anatomic center of the ACL footprint, within a couple of millimeters. So we did that. It didn't seem quite believable at first, but then several other laboratories did the same thing, and it was clear that using the sort of standardly used transtibial techniques, one could not get it in the appropriate location. We then looked at people, subjects, patients who had had ACL surgery either by the transtibial or the anatomic technique. So when we looked at patients, we used high-resolution MRI and validated that with cadaveric studies. And we found that we used more than 10 subjects who had transtibial or anatomic. And what we found is that the same thing we found in the laboratory. The center of the tunnel in the subjects who had transtibial ACL reconstruction, the center of the tunnel was outside the center of the normal footprint. And we also got MRIs of the opposite knee and were able to get the footprints. So the anatomic studies in patients and the cadaveric studies both showed the same thing, that we were much more precise with the anatomic, or at the time we were using that, and still are using the outside-in technique with either the retro cutter or the flip cutter. Now, does it make a difference whether it's outside in or transtibial? We had a technique developed primarily by Lou DeFrade in our lab that looked at in vivo kinematics of the knee by using high-resolution MRI techniques of each side and getting simultaneous two-dimensional fluoros so we can find out precisely where the bone is. And then if we map the MRIs onto the bone, we can find out exactly where the cartilage is contacting, where the relative positions of the femur and the tibia are. And using the same patients who had had either transtibial or anatomic ACL reconstructions, we found that the kinematics of the knee, how the femur and the tibia are related to each other, were much more normal in the anatomically placed grafts. In fact, there weren't statistical differences in translations and rotations between the anatomically placed grafts and the normal knee, the other knee. On the other hand, with the transtibial grafts, again, who were doing well, they were off. They even started off in extension in 3 millimeters of anterior subluxation. What that means, you hope, is that you're going to end up with less arthritis and less degenerative change. And there actually have been other animal studies to point that out, that dogs with partially transected ACLs versus completely transected, the more instability there is, the more arthritis there is in the long run. The next thing we did was, with that technique, we can see the cartilage thickness within less than a tenth of a millimeter resolution. And we're finding differences in the cartilage thickness in the 2 different methods of reconstruction. We think that the cartilage thickness changes look better, and they look more like the other side in the anatomically fixed group. There is a question now whether we're better off going back to old ways of doing things, because some of the European registries seem to be showing higher rates of re-tear in patients with more anatomically placed grafts. The European registries are done by a wide variety of surgeons, each with a relatively small number of cases. So there's nothing really very well controlled about how the cases are done. But I wouldn't be at all surprised if a good study did not show that is true. What you're trading it for is that the normal kinematics are worse in the non-anatomically placed grafts. I think I'd rather have a lifetime of good kinematics rather than a little higher chance of re-tear. Plus, divine intervention or 500 million years of evolution didn't put the ACL where it is because there was a better place to put it. You know, it just doesn't make sense to me to not restore anatomy the way that it was. There's also the question of fixed loop suspension or the tightrope. We had done fixed loop for many years, and then we switched to the tightrope. The fellow said, maybe we ought to look them up. And my good idea was, yeah, go do that. So we had about 100 with the fixed loop, and we had about 100 with the tightrope, and we didn't find any difference with KT 1000s and with stability tests, radiographs. They were the same, and both groups averaged about 1.5 millimeters difference on the KT 1000. So they were both quite acceptable. I feel very confident that we can get an anatomic reconstruction with good biomechanics and good situation for biological healing with the retro cutter, the flip cutter, the suspensory fixation, and the tightrope. Our failure rate is acceptable. The KT 1000s are acceptable. We still have the problem, grafts fail. People go back to sports. I think we have a much bigger problem now with rehab and biology of when to go back and how to recover than we have with surgical techniques. I think our surgical techniques are pretty good right now. Excellent.